Hi, my name is Beth DeYoung. I'm an assistant professor of pharmacy practice at Concordia. I also work at the Milwaukee VA where I run a metabolic syndrome monitoring clinic for patients taking second-generation antipsychotics. Most of my training has been in mental health, and today I will be talking to you about the medications that we use to treat depression. These learning objectives do not cover everything that I think is important or everything that you should know in order to competently practice in treating depression, but the objectives do cover what I think is important in terms of what you should know for the exam. So you should be able to recall the mechanisms of actions of the antidepressants to aid in the selection of the best antidepressant for a certain patient, describe potential drug-drug and drug-food interactions when presented with a medication profile, compare and contrast the significant adverse effects of the various antidepressants, determine the appropriate washout period required when switching to or from a monoamine oxidase inhibitor to prevent serotonin syndrome, and then evaluate a patient's characteristics to select the best antidepressant for a given patient. You may already be familiar with the phases of depression, but we'll really be looking at these phases in terms of treating with medication. So there's 3 different phases: the acute, continuation, and maintenance phases. If you're going to start an antidepressant in a patient, you typically will start it in the acute phase, and our goal is to induce remission. Remission is defined as the absence of symptoms and full return to baseline level of functioning. This lasts typically about 6 to 12 weeks. The patient will then go into the continuation phase, and you'll continue the same medication as long as it's effective for the patient and not causing side effects. And here our goal is to preserve remission and prevent relapse. Relapse is defined as return of symptoms within 6 months of remission. So for all patients, the minimum duration of treatment should be approximately 7 months. If you look at kind of the time frames given for the acute and continuation phase, we've got about 3 months for the acute stage and 4 for the continuation phase. I will say, clinically speaking, most patients are treated for about a year before a decision is made to either take them back off the antidepressant or try to reduce the dose. Many patients will go into the maintenance phase, and this can last indefinitely. Some patients will need to be treated for life. We typically consider this in patients who've had 3 or more previous episodes of depression. If they've had this many episodes of depression, typically the benefits of staying on the antidepressant will outweigh the risks. And here our goal is to prevent recurrence, and recurrence is defined as a separate episode of depression. This image just depicts the previous slide that we talked about, so it's just to help those of you that are a little bit more visual. You can see, looking at this image, the difference between relapse and recurrence based on if the patient's in remission or if they already recovered from the illness. This table highlights the various treatment options according to the American Psychiatric Association. You can see with mild to moderate illness, they recommend pharmacotherapy and psychotherapy, that both would be effective treatment options. Psychotherapy is comparable to pharmacologic intervention and may be preferred by some patients with mild to moderate depression. We won't worry about the severe with psychotic features, but we'll focus more on the severe without psychotic features. And you can see here that with severe depression, antidepressants appear to be more effective than psychotherapy and have more rapid onset. So that's why we'll want to consider them in patients with severe depression. Combinations of medications and psychotherapy is typically found superior to either intervention alone, but is not always feasible for all patients. Non-pharmacologic therapy is not the focus of today's discussion, but I just want to mention it because don't want to forget about these treatment options for patients. As mentioned, sometimes used in combinations with medications, they can work very well. Sometimes used on their own, they work very well, especially for those patients with mild to moderate depression. There are several different forms of psychotherapy. I just have a few listed here. The first one is cognitive behavioral therapy. This typically focuses on patterns of thinking that are maladaptive and the beliefs that underlie that thinking. Patients will typically learn to restructure negative thought patterns and learn to view challenging situations more clearly and learn how to more effectively deal with them. Interpersonal therapy is kind of working on family relationships and interpersonal relationships, while psychodynamic therapy focuses on the psychological roots of emotional suffering and uses a lot of self-reflection and self-examination. And then problem-solving therapy is basically what its name sounds like. It's learning to deal and solve problems in a more effective and structured manner. Many of us have heard of and are familiar with electroconvulsive therapy. Electroconvulsive therapy actually has the highest rates of response and remission. However, it's typically just used for treatment-resistant depression or if a patient prefers it. One thing to note is that it's actually safe to use in pregnancy, so sometimes patients will prefer that over taking medications. It's usually administered 2 to 3 times a week for about 6 to 12 sessions. It's not free of side effects, though. It can cause things like headache, muscle aches, confusion, and increased heart rate and blood pressure. Next, we have transcranial magnetic stimulation, which I have pictured in the top image. With this, a large electromagnetic coil is placed against the scalp, and it creates an electric current that stimulates nerve cells in the regions of the brain that help control mood. This is used occasionally. I don't see it too often, but several facilities do use this treatment modality. Vagus nerve stimulation is not very common. That's actually pictured down in the bottom image, and I think of it sort of similar to a pacemaker, in which it's actually implanted under the skin and then sends electrical impulses into the brain to improve depression. Light therapy, this is often used with seasonal affective disorder. They'll have patients gaze into a light box for approximately 30 minutes per day. And then there are also several other non-pharmacologic therapies that I don't have listed. We have exercise up there, but then things like yoga, meditation, journaling, acupuncture, these are all potential things that a patient can use to help with depression. We have several pharmacologic treatment options available to us, and I have them broken down into first and second line treatment options. Our first line treatment options are going to be our selective serotonin reuptake inhibitors, our serotonin, norepinephrine, and reuptake inhibitors, and then mirtazapine and bupropion. Things that are used second or even further down the line are monoamine oxidase inhibitors, tricyclic antidepressants, things like trazodone and nifazodone, vilazodone, and vortioxetine. Vilazodone and vortioxetine are new to the market, so it's just that we don't really know their role in therapy yet, and that's probably why they're used second line. They're also very expensive at this time. There are also several other treatments that we won't have time to talk about today. I won't get to talk about any of these treatments, but we have several complementary and alternative treatments that are available over the counter, things like St. John's wort, SAMe, omega-3 fatty acids or fish oil, vitamin D, and L-methylfolate. There's also prescription augmentation strategies that you may see psychiatrists use, things like second-generation antipsychotics, lithium, thyroid replacement, and stimulants. All classes of antidepressants are equally efficacious. If you look at any given patient, certain patients may respond better to certain medications, but in the general patient population, there's nothing showing that one agent is more efficacious than another. So the choice of agent is really going to depend on multiple factors such as side effects, comorbid conditions, patient preference, or if they have a family or their own history of response to a medication. The cost of the drug is usually very important to patients, as well as drug-drug interactions. Listed here are the selective serotonin reuptake inhibitors that we have available on the market. I have them listed in both generic and brand name. Pharmacists tend to speak in generic, and many of the psychiatrists or patients tend to speak in brand name. So throughout the presentation, I'll be referring to these with their generic names, but here's the brand if you also would like to know those. Fluvoxamine is not actually used for depression anymore. We'll still use it for anxiety, but it's not really used for depression for reasons we'll talk about later. So then listed here are serotonin and norepinephrine reuptake inhibitors. Deslinavaxine and levomilnacipran are still brand name. Levomilnacipran is actually one of the newest antidepressants on the market, and it's actually an isomer of milnacipran, which was approved for treatment of fibromyalgia and has been on the market for a while. So levomilnacipran appears to just be a stronger inhibitor of norepinephrine reuptake than venlafaxine or duloxetine, but there's no proof at this time that it's any more effective than the other agents. Desvenlafaxine is actually the active metabolite of venlafaxine, and there's also no evidence that it's any more effective than venlafaxine. Duloxetine is used also to treat fibromyalgia and diabetic peripheral neuropathy. So sometimes this is a great option for patients that have neuropathic pain and depression. And our miscellaneous first-line agents are bupropion and mirtazapine. Bupropion can also be used for smoking cessation, in which case then it is marketed under the brand name Zyban. In terms of mechanism of action, the selective serotonin reuptake inhibitors do exactly what their name implies. They inhibit the reuptake of serotonin from the synapse. It's pretty nice because they don't have a lot of effect on muscarinic, histaminergic, or alpha-adrenergic receptors, which can cause a lot of side effects that we'll see with agents that we'll talk about a little bit later. From a mechanistic perspective, just recall that with muscarinic receptors, you can end up with anticholinergic side effects, histamine receptors, sedation and weight gain, and with alpha-adrenergic receptors, you can end up with orthostatic hypotension. You'll also notice that I have something listed here with the desensitization and downregulation of presynaptic serotonin 1A autoreceptors. So the 1A autoreceptor is really responsible for letting the neuron know that there's already serotonin in the synapse. So when serotonin is released in the synapse, it'll feed back on that 1A autoreceptor, which is actually in the image on the slide, it's shown as a 1B autoreceptor, which is fine, don't worry about that. But it feeds back on this 1A autoreceptor and says, hey, there's enough serotonin in the synapse, don't release any more. Well, it takes a while for that to desensitize and downregulate, and part of this then may be responsible for the delay in onset of SSRIs. The SNRIs inhibit the reuptake of serotonin and norepinephrine, and then I also have listed there that venlafaxine inhibits serotonin reuptake at low doses and norepinephrine reuptake at higher doses. So typically at doses less than 150 milligrams per day, venlafaxine is mainly inhibiting the reuptake of serotonin. Once you get above that 150 milligrams per day, that's where you'll start to see norepinephrine inhibition. Bupropion inhibits the reuptake of norepinephrine and dopamine. So this one's a little bit different than the others in that we don't have action on serotonin, which can be nice mechanistically because this is a good medication then to sometimes combine with our SSRIs or SNRIs. There's really not really great evidence for combining two SSRIs or an SSRI and an SNRI, but adding bupropion to either of these takes advantage of a different mechanism and may promote efficacy for the patient. Mirtazapine also has a little bit different mechanism, and that is a central alpha-2 receptor antagonist, and this causes serotonin and norepinephrine to be released into the synapse. So it's similar to the SNRIs in that its primary focus is on serotonin and norepinephrine, but instead of inhibiting their reuptake, it actually causes more to be released into the synapse. It's also an antagonist at serotonin 2 and 3 receptors, and this results in lower anxiety, sexual dysfunction, and gastrointestinal side effects. And then, unfortunately, it's also an antagonist at histamine 1 receptors, which can result in drowsiness and weight gain. So with serotonin 2 stimulation, this is thought to be responsible for sexual dysfunction, possibly some akathisia and agitation, as well as insomnia, while serotonin 3 stimulation is thought to be responsible for gastrointestinal adverse effects. So that's why with mirtazapine being an antagonist at these receptors, it's thought to have lower amounts of sexual dysfunction and gastrointestinal side effects. In terms of the pharmacokinetics, I don't expect you to have these numbers memorized for things like half-life. The numbers are different than what you may see in your text, and that's okay, again, because I'm not expecting you to have these memorized. I just want you to have a general idea. And one of the biggest things to take away from this is that fluoxetine has a very long half-life. It will stay in the body for a long period of time. If you look, all the other agents are listed in terms of hours, whereas fluoxetine has a half-life of 4 to 6 days. And its active metabolite, norfluoxetine, actually has a half-life of 4 to 16 days. So very long time that it stays in the body. Some of the other agents like venlafaxine, desvenlafaxine, duloxetine, they all have fairly short half-lives, and that'll be kind of implicated a little bit later in some withdrawal symptoms that we'll talk about. All of these agents, you have to pay a little bit of attention to renal and hepatic adjustment. However, I will say that it's generally safe to use these agents in patients with renal and hepatic impairment. The dose adjustment recommendations are usually fairly vague, and where they'll maybe recommend dose adjustments but not be too specific in how to go about that. So sometimes it just says may require a lower dose. With the SNRIs, venlafaxine, desvenlafaxine, duloxetine, levomilnacipran, those are cleared renally. So if you have a patient with renal impairment, it is important to make sure that you're adjusting the doses appropriately. There's a lot going on this slide, and these medications are pretty highly implicated in drug-drug interactions. It's important to recognize that pretty much all of these medications are metabolized by CYP450 enzymes, but they also inhibit the CYP450 enzymes. And so this is what this table is showing you. It's showing you the CYP enzyme inhibitory potential of each medication. And rather than memorizing which enzyme is inhibited by every single drug, what I want you to notice is that fluoxetine and fluvoxamine are most involved with this CYP inhibition. And this is one of the reasons we don't really use fluvoxamine for depression. We have a lot of other agents that are effective, and there's just no need to deal with all those drug-drug interactions. So of the agents we use, fluoxetine is the one that's most implicated in drug-drug interactions. Paroxetine and sertraline kind of fall in the middle. And then citalopram, escitalopram, and the SNRIs are all pretty good. If you had to pick one for a patient that was on multiple medications, any of those agents would be reasonable, as well as bupropion and mirtazapine. I had mentioned when I talked about the mechanism that there is a delayed onset with these medications. Typically, you will notice improvement within 1 to 2 weeks of starting them, but it can take anywhere from 4 to 6 weeks, for some patients maybe even up to 8, to recognize the full therapeutic effect of these medications. And again, that's thought to be due to the time it takes to desensitize and downregulate that serotonin 1A receptor. While that receptor is working, the serotonin feeds back on it and again tells it not to release more serotonin into the synapse. So it takes a while for that to burn out, so you can get more release of serotonin into that synapse. One thing that's difficult for patients is that onset of side effects is immediate. So it can be very difficult for them to tolerate the medication if they're experiencing side effects. They may want to discontinue it right away before they really get a chance to notice any benefit from the medication. Escitalopram is the S enantiomer of citalopram. It is more potent. The R enantiomer that's also included in citalopram does not actually contribute to the efficacy, but is thought to maybe contribute to side effects. However, both agents are equally efficacious. And then I've already mentioned that desvenlafaxine is the active metabolite of venlafaxine. In terms of symptom remission, you should notice some benefit in those first couple of weeks. Usually the first thing to improve is things like sleep and appetite. Within 1 to 3 weeks, you'll notice increases in activity, improvements in memory. Patients may say that their eating patterns and sleeping patterns are pretty normal by now. And then within 2 to 8 weeks, that's where you start to see the relief of depressed mood, patients being less hopeless and helpless, and thoughts of suicide. So if you're not noticing benefits within those first few weeks, may mean that you need to increase the dose or potentially even consider switching agents. However, it's important to recognize that it can take up to 8 weeks for full effect, so you don't want to give up on the antidepressant too early. Great. I just want to highlight some of those drug-drug interactions and use some patient cases to show you some potential issues you could run into. So with the first case, we have a patient that has been taking metoprolol tartrate for the past year for hypertension. He has started on paroxetine to treat depression. Paroxetine inhibits CYP2D6, which actually metabolizes metoprolol. So if CYP2D6 is inhibited, metoprolol cannot be metabolized as quickly, and this increases the risk for bradycardia and hypotension. So you could potentially just pick a different antidepressant. However, almost all of them have some CYP2D6 inhibition. Or if necessary, you could switch to a different antihypertensive. Otherwise, clinically speaking, what you should just do is have the patient monitor their heart rate and blood pressure. If their heart rate already isn't too low, like less than 50, this really shouldn't be too much of an issue for patients, but you do want to counsel them on that they could feel dizzy or lightheaded, and that it's important to monitor their blood pressure and pulse. With the second case, we have a patient who is prescribed clopidogrel after suffering a myocardial infarction with stent placement. He started on fluoxetine for depression. Fluoxetine is a CYP2C19 inhibitor, which can reduce clopidogrel efficacy. CYP2C19 is responsible for converting clopidogrel's prodrug to the active metabolite. So basically, fluoxetine inhibits the enzyme which makes clopidogrel more active, and therefore clopidogrel may not work as well for this patient. Once again, you could just pick a different antidepressant that doesn't have this CYP2C19 inhibition. And then for the third case, we have a patient that has been taking citalopram for depression for the past 5 years. He is currently hospitalized with pneumonia and will be treated with linezolid. So linezolid is actually an inhibitor of monoamine oxidase, and we'll talk about this a little bit more later when we talk about the monoamine oxidase inhibitors. But with that, due to that inhibition of monoamine oxidase, you can actually get buildup of the neurotransmitters, and this can place the patient at risk for something called serotonin syndrome, which we're going to talk about next. So what I want to highlight with these cases is that drug-drug interactions can be pretty problematic. It's not that I'm expecting you to memorize, again, which ones inhibit certain CYP enzymes, but I want you to realize which antidepressants tend to be more problematic, with the most problematic being fluvoxamine and fluoxetine. So if you get a patient case where a patient's on multiple medications, especially cardiovascular medications, you would not want to pick fluoxetine as your first-line agent. So as that last patient case alluded to, we need to be careful with other medications that can increase serotonin in the synapse. And I have several medications listed here. This list is not all-inclusive, but our other antidepressants, monoamine oxidase inhibitors, tricyclic antidepressants, our SSRIs and SNRIs, all of them increase serotonin in the synapse, so we have to be careful using them in combination. I've already mentioned in that case that linezolid can do this as well. Our triptans, which we use to treat migraines, so things like sumatriptan, and then several synthetic opioids can cause serotonin syndrome when used in combination with antidepressants. And so you can see up there we have meperidine, propoxyphene, methadone, tramadol. So you really have to be careful when adding multiple serotonergic medications onto a patient's profile. The highest risk is with monoamine oxidase inhibitors, and really the only times I've seen serotonin syndrome actually happen is when a patient is on a monoamine oxidase inhibitor. All right, as mentioned, serotonin syndrome is caused by excessive central nervous system serotonergic activity, and it's usually associated with the use of multiple serotonergic agents. However, it can occur with one agent alone. And then I also said that the highest risk is with use of a monoamine oxidase inhibitor, although it could happen with like anything like an SSRI or an SNRI. The symptoms can be fairly nonspecific in the beginning, things like abdominal pain, diarrhea, sweating. Sometimes patients will be shaky, but then they can develop more severe symptoms, including things like rhabdomyolysis, renal failure, cardiovascular shock, and death. So it is very important that patients are counseled on how to recognize these signs and symptoms, and that healthcare providers can also help recognize them and initiate prompt treatment if necessary. There is something we can do to help prevent serotonin syndrome, and that is that we should have a washout period when switching to or from a monoamine oxidase inhibitor. If a patient is on an MAOI and you switch them to a non-MAOI, you should have a 2-week washout period in which they do not receive the new antidepressant. Also, any medication without a long half-life, if they're on any other like paroxetine, venlafaxine, a tricyclic antidepressant, and you're going to switch to a monoamine oxidase inhibitor, you also use a 2-week washout period. And then the only one that's different is fluoxetine. And we mentioned already that this one has a very long half-life, so it stays in the body for a long time. So with this medication, you need a minimum washout period of typically about 6 weeks. So if you just remember the 6 weeks for fluoxetine, and with every other scenario, you need a 2-week washout period. In terms of dosing, you'll typically titrate the dose over the first few weeks as tolerated until you reach a therapeutic dose or the patient responds well to the dose that they're on. Again, you should see improvement in 1 to 2 weeks, but maximal response may not be reached for 4 to 6 weeks. Minimum effective doses have not been clearly established for many of the antidepressants, and the dose-response relationships tend to be unclear. So for this reason, you may see providers exceed the maximum recommended dose. Just use caution with doing so. Slower titration may be necessary for the elderly, patients with renal and hepatic impairment, those who have multiple comorbid conditions, patients who are taking medications that can involve drug-drug interactions that we talked about. Those are the types of patients where you may not be able to escalate the dose as rapidly. So you really need to weigh the benefits and risks of exceeding the maximum recommended doses. And as I've already said, this does happen in clinic, but you just have to recognize that sometimes you don't get more benefit. You just end up with more side effects. With citalopram, there's actually a recommendation to not exceed 40 milligrams due to the risk of QTc prolongation. They actually say not to exceed 20 milligrams daily if your age is greater than 60, in patients that have impaired CYP2C19 metabolism, or if they're on concomitant CYP2C19 inhibitors. Sometimes the problems that you run into with dosing can be that patients or providers will inappropriately increase the dose or do inappropriate dose reductions. You can see inadequate treatment durations in which they don't treat the patient long enough and give up on the medication too quickly, or where they'll just do a kind of a one-dose-fits-all strategy. I'll often see providers, just do small doses of antidepressants rather than getting to a good dose that really helps the patient. I don't expect you to have dosing memorized. This is something that can be looked up, and as mentioned, a lot of times providers will exceed the maximum recommended dose, so I don't need you to memorize those. I just want to point out a few things on here. Several of the medications can be dosed once daily. However, there are some that need to be dosed multiple times per day, which can affect adherence for patients. Duloxetine dose, typically with depression, we'll see people won't usually exceed around 90 milligrams. Those higher doses around 120 are usually used for neuropathic pain and peripheral neuropathy. And then paroxetine and mirtazapine are usually administered at bedtime to help with sedation. We'll talk about how those medications can make people feel sleepy, so it's helpful to have patients take those at bedtime. Another reason you'll often see doses divided twice daily is to help minimize side effects. Sometimes if a patient is not able to tolerate the full dose taken once daily, you can divide it twice daily to help with that. It's important when you're going to stop an antidepressant to not just abruptly discontinue it. And it's also important to inform patients that they shouldn't abruptly stop their antidepressant. And this is because patients can develop a discontinuation or withdrawal syndrome. This happens most commonly with agents that have shorter half-lives like paroxetine and venlafaxine, and it's least common with fluoxetine due to that long half-life. The symptoms generally resolve over 1 to 2 weeks, and they're not life-threatening, but they are uncomfortable. And so you can see many of the symptoms listed there are sort of like flu-like symptoms. Paresthesias are actually kind of like tingling, burning, pricking, or numbness of the skin. I've often had patients describe that they feel like they're being kind of shocked by electricity when they abruptly stop their antidepressant. In terms of adverse effects, we're going to focus more on the common adverse effects with these agents. A big one for patients can be nausea, vomiting, and diarrhea. And these do tend to diminish after the first week or two of treatment. You can have patients take the medication with food or a snack to help minimize those adverse effects. But typically, if they can get through that first week or two, things will get better for them. Sexual dysfunction can be problematic with this entire class of medications, and it's important to ask patients about that. I often find that they're not really willing to divulge that information on their own, but they're often very relieved if you ask about this, and this can occur in both males or females. There are several things that you can do to help improve that. You can either try reducing the dose or maybe switching to a different agent. Bupropion is actually not associated with sexual dysfunction because remember, it does not work on serotonin, so you don't get that sexual dysfunction with it. So sometimes adding a low dose of bupropion can actually help, or adding something like a phosphodiesterase inhibitor like Viagra if necessary. You can see weight gain with certain agents. We'll talk about which ones here in a moment. Some of them can make patients sleepy, while some of them can actually cause insomnia. And then they can cause anxiety or agitation when first started. It's a little counterintuitive because we actually use these agents to treat anxiety, but in the first week or two, patients can actually feel a little more anxious when starting some of these medications. In terms of less common side effects, bruxism is actually teeth grinding, so you can see that due to the effects on serotonin. GI bleeding, this can occur due to blockade of serotonin reuptake into platelets. So if you remember, serotonin is actually involved in platelet aggregation, so through its actions here, it can actually cause bleeding. SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone. This more commonly occurs in elderly patients or those that already have hyponatremia. And then akathisia or dystonic reactions. These are actually movement disorders, and this can occur because serotonin reduces dopamine levels, which is involved in movement. So this is a pretty important slide because often we will choose agents for patients based on the propensity to cause certain side effects. And so this really differentiates, even though a lot of the side effects we just talked about are class effects and you can get it with any single one of the agents, there are certain agents that are more likely to cause certain side effects. Bupropion and fluoxetine tend to be more activating. These are ones that can cause more of that anxiety or agitation that I mentioned. They also can cause insomnia, so we often dose them in the morning. Paroxetine is associated with anticholinergic side effects. So again, these are drying side effects. I think of things like dry mouth, difficulty urinating, constipation. This medication can be particularly problematic in elderly patients. Sertraline tends to cause more diarrhea. Patients tend to get adjusted to this, but it can be problematic for some patients. The SNRIs as a class can cause hypertension, but it tends to be worse with venlafaxine. And then I already mentioned that mirtazapine and paroxetine cause sedation, so we typically dose those at bedtime. Bupropion can lower the seizure threshold, so it's recommended not to give that medication to patients with any history of seizures. All of them cause sexual dysfunction, but paroxetine, usually in studies, is one of the ones that turns out to be the worst for patients. Your textbook actually mentions that paroxetine tends to be better for males, but I have not seen this clinically speaking, and as I mentioned, a lot of studies, paroxetine tends to do the worst. And then mirtazapine and paroxetine are the most problematic in terms of weight gain. In terms of monitoring, there's not a lot that we have to do with monitoring labs or anything like that, or checking levels with these medications. So the frequency of monitoring really varies because we're just really checking on response to treatment, side effects, if the patient's being adherent with the medication, and assessing for any type of suicidal ideation. You can check response to treatment using rating scales, things like the HAM-D rating scales, or a clinical interview. And then the appropriate appointment frequency really kind of depends on the severity of the illness, how much social support the patient has, any progression of symptom change. Typically, if you're starting an antidepressant, you will see the patient every week or two to adjust doses and kind of check for side effects. Thereafter, follow-up, again, will really just depend on how well the patient is doing. There are certain patient populations that we want to pay particular attention to, and one of them is the elderly. The elderly have a very high rate of suicide, and especially elderly men, because they have high access to guns and they're just usually don't have as much social support, so they're more likely to commit suicide. They often present with more physical complaints. So depression can actually be missed in these patients due to physical complaints of things like headache, insomnia, joint pain, dizziness, constipation. These are all actually things that can be signs of depression in an elderly patient. They also may be more sensitive to side effects. We talked about paroxetine maybe not being ideal in our elderly patients due to those anticholinergic side effects. The elderly are more at risk for SAADH as well as movement disorders with the antidepressants. You also want to consider renal and hepatic function in this patient population, as it's often decreased as we age. Elderly patients are usually on more medications, so we have to be cognizant of those drug-drug interactions. And then you may need to do a slower dose titration in this patient population to help prevent some of those side effects. On the opposite end of the spectrum, we also have to take special consideration with our pediatric patients. Unfortunately, there is not a lot of great data in this area, especially with regards to medications. These patients are more likely to present with irritable mood than what you'd think of as a typical depression, so just make sure to watch for that, especially in teenagers. And then fluoxetine is actually the only antidepressant that's FDA approved for depression in pediatric patients. However, you will see pretty much all of them used, the SSRIs and SNRIs, but I just want to point out that fluoxetine is the only one with an indication. And then all of them have a black box warning that warns about the increased risk of suicidal thinking and behavior in children and adolescents as well as young adults. And so what we've seen clinically is that this black box warning is not really consistent with the most recent research and clinical experience. Actually, after this warning came out and prescribers started prescribing less antidepressants, the suicide rates actually increased in this patient population. So you still want to make sure that you're providing treatment if a patient needs it, but it's very important to provide counseling, especially to the parents, to make sure that they're monitoring for any suicidal thinking or behavior. And then in terms of pregnancy, SSRIs have the most published data on efficacy and safety. Paroxetine is the one that you have to take special note of. That one is pregnancy category D, and that's because in 2005 there was an FDA advisory indicating that paroxetine may increase risk for cardiac defects. Subsequent studies showed no increase in major birth defects with paroxetine, but it is still listed as pregnancy category D. Not sure that that's necessary, but if you have a lot of different options to choose for a patient, paroxetine may not be best anyways in a pregnant patient due to increasing risk for things like constipation. SSRI use during pregnancy may be associated with things like low birth weight, premature birth, and then withdrawal symptoms after the baby's born, and this can be a wide variety of things like irritability, jitteriness, difficulty feeding, and tremors. So a lot of pregnant women will worry about taking these medications while pregnant. However, it's important to counsel them that untreated depression is also associated with premature birth and low birth weight. So in all of these studies, both untreated and treated women basically had the same outcomes, or their babies basically had the same outcomes. So again, you really need to weigh the benefits and risks, and it's important to treat someone who has, moderate to severe depression if a patient is feeling suicidal. Obviously, committing suicide would be a worse outcome than staying on an SSRI during pregnancy. Sometimes providers will continue the SSRI and then try to discontinue it in the third trimester, but again, this is very patient specific. You wouldn't want to stop an SSRI if a woman truly needs it. It would just be better to continue it throughout the pregnancy. These agents are excreted in the breast milk, some more than others. Sertraline is actually excreted least and fluoxetine the most. So if you have a mother that's breastfeeding, any of the agents should be fine, but if they want to be particularly careful, I would stay away from fluoxetine. Sometimes when this is excreted in breast milk, it can cause things like irritability, vomiting, and diarrhea. And kind of thinking about these agents and summarizing what we've learned, there's really a lot that goes into patient education when you're starting a patient on one of these medications. It's really important that you counsel them on that delayed onset, when they can expect to see side effects versus when to expect benefits, so that hopefully they can stick it out and get a good trial of the medication. What types of drug-drug interactions they need to be aware of, what signs and symptoms of serotonin syndrome look like. It's important they do not abruptly discontinue the medications so that they don't get those withdrawal effects. And then counseling on the common adverse effects that happen, things like nausea, vomiting, diarrhea, sexual dysfunction, changes in weight, potentially increasing anxiety in that first week. And then suicidal thinking is important to counsel for all patients. Patients should also avoid alcohol. As you know, alcohol is a depressant, so it kind of counteracts the antidepressant. And then counseling patients if they plan to become or are pregnant. We are now going to shift gears and move in and talk about some of our second-line treatment options. We do have several monoamine oxidase inhibitors. As primary care nurse practitioners, you are not likely to ever be starting these agents on a patient. Typically, a psychiatrist would be doing this, but I still want to highlight them to talk about why we don't use them first line and what are some things you might run into if you have a patient that's already on one. All of them are oral except for selegiline, the transdermal system, because that one is actually available in a patch form, which can be kind of nice for some patients. The mechanism of action of these medications can be somewhat confusing for patients, and the first thing to recognize is that there's two types of monoamine oxidase. There is monoamine oxidase A and monoamine oxidase B, and these things are responsible for metabolizing serotonin, norepinephrine, and dopamine in the case of MAO-A, and dopamine in the case of MAO-B. They're also responsible for metabolizing something called tyramine, which we'll talk about here in a moment. They're also a little bit different in terms of where the enzymes distribute in our tissues in the body. So you can see the different agents have different types of properties. Across the board, they all pretty much inhibit MAO-A and MAO-B. Tranylcypromine also has some amphetamine properties. Amphetamine is actually a weak MAO inhibitor. And then simultaneous inhibition of MAO-A and MAO-B results in a robust boost of dopamine as well as serotonin and norepinephrine. It's important that none of them just inhibit MAO-B because MAO-B inhibition alone is not effective for depression. These medications are highly involved in drug-drug interactions, which is one of the reasons they're not used first line. We already talked that this group is the highest risk for causing serotonin syndrome if combined with other serotonergic drugs. It can also cause hypertensive crisis if combined with some pathomimetic drugs or foods containing tyramine. This list is not all-inclusive, but these are some examples of some pathomimetic drugs, so things we use to typically treat ADHD like amphetamines and methylphenidate, decongestants like pseudoephedrine or phenylephrine. So we really want to avoid other agents that stimulate alpha-1 receptors excessively because this can put the patient at risk for hypertensive crisis when combined with monoamine oxidase inhibitors. So tyramine is actually a potent releaser of norepinephrine, and that's why you have to be careful with foods that contain tyramine. If you have something that's a potent releaser of norepinephrine, and then you also have a monoamine oxidase inhibitor increasing norepinephrine in the synapse, all of that norepinephrine really can increase your risk for a hypertensive crisis. I have several foods listed here. This list is also not all-inclusive, but some of the more common things of foods that patients should avoid if they're on a monoamine oxidase inhibitor. So you have to make sure to provide appropriate counseling on this and really have a patient that's diligent about this. Usually these foods in small amounts are fine, but we typically counsel patients not to eat any because it becomes confusing on how much they can actually consume before it becomes dangerous. These medications also have some pretty problematic side effects, and that's another reason we don't use them first line. We see quite a bit of orthostatic hypotension, especially with phenelzine. They can also cause weight gain and sexual dysfunction, which patients don't like. And then we'll see sedation with phenelzine, insomnia with tranylcypromine, and then also potentially some movement disorders. These agents are also lethal in overdose, so you would not want to give them to a patient who's acutely suicidal. We're now going to move on and talk about the tricyclic antidepressants. And again, this is probably not something you would prescribe for depression, but I just think it's important you recognize why we don't use them first line for depression and what are some potential things you need to be aware of if you see a patient on these medications. I have a few of them highlighted in blue. These are the agents that I tend to see most frequently, nortriptyline and amitriptyline for depression, and clomipramine and imipramine for anxiety. These agents tend to be more used for things like neuropathic pain, migraine prophylaxis, and things like obsessive compulsive disorder, more so than depression. You will notice that the secondary amines are less anticholinergic than the tertiary amines. So if you had to select one for an elderly patient, nortriptyline is usually the one that people will choose just because it's usually less problematic in terms of side effects. The tricyclic antidepressants also work by inhibiting the reuptake of norepinephrine and serotonin from the synapse. They also have a desensitization process that must occur. This time it's with the alpha-2 autoreceptors, and so the time that it takes for this desensitization can cause a lag in mood elevation for these agents as well. So just like the SSRIs and SNRIs and pretty much all the agents we talked about, you won't see improvements in mood for at least 2 to 3 weeks. These agents are not used first line due to all their side effects, and that is because of part of the mechanism of these agents. With the blockade of muscarinic receptors, we will see anticholinergic side effects. With blockade of histamine receptors, we'll see sedation and weight gain. With alpha-1 receptors, we get quite a bit of orthostatic hypotension. And then with these voltage-sensitive sodium channels, this can actually cause seizures and arrhythmias. Just like the other agents we've discussed, these medications are also involved in CYP450 interactions and serotonergic interactions, so we still have to be careful for serotonin syndrome. And then tricyclics are highly protein bound, which can cause interactions through displacement from protein binding sites. So you have to be careful if they're combined with things like valproic acid, which is a very highly protein bound drug. So this is a list of all those side effects I was referring to when I talked about the mechanism. And you can see here that we have some pretty severe side effects listed, like cardiac arrhythmias, tachycardia, heart block, and seizures. These medications are also lethal in overdose, so you would not want to give them to a patient who's acutely suicidal. Or for patients that are at risk at suicide, you'd want to give them a very small amount so they couldn't overdose on them. We're now going to briefly talk about some miscellaneous agents. Trazodone and nafazodone are kind of categorized as serotonin antagonist reuptake inhibitors. I have it abbreviated there as SARIs, but no one actually refers to them by that abbreviation. These agents have a dual action on serotonergic neurons. They have potent serotonin 2 antagonism, which should avoid side effects like sexual dysfunction, and then weak serotonin reuptake inhibition. They also block alpha-1 adrenergic receptors and block histamine receptors, specifically trazodone. So you'll see quite a bit of sleepiness with trazodone. Trazodone is most commonly used as a sedative due to that reason. We tend to use low doses to treat insomnia, so doses around 25 to 250 milligrams. You don't actually get an antidepressant effect at doses less than 150 milligrams, and it may even take 300 to 600 milligrams to get an antidepressant effect, and patients are just way too sedated at that dose. So that's why we really don't use trazodone anymore as an antidepressant. You'll see a couple of side effects that I've highlighted on this slide. For trazodone, it can cause priapism, which is a sustained erection. This can actually occur in about 1 in 6,000 patients, and some actually have required surgical intervention, so it is important to counsel patients on that potential side effect. Nafazodone has a black box warning for hepatotoxicity and does require liver function monitoring. For that reason, nafazodone really is not used to treat depression much anymore either. So you really are unlikely to see nafazodone or trazodone used for depression. You're more likely to see trazodone used for insomnia. We're going to conclude by talking about a couple of the newest agents on the market, vilazodone and vortioxetine. Vilazodone is a fairly new antidepressant, so its place in therapy is really unclear. We do know it's expensive, so it may be worth trying if a patient has good insurance and they have tried multiple other agents, but it may not be the best option if a patient is paying out of pocket. It has a unique mechanism in that it's a dual SSRI and a partial agonist at those serotonin 1A receptors. This is thought to decrease the time to effect and to decrease kind of that lag time. It actually stimulates that serotonin 1A receptor, causing it to burn out faster, thus eliminating negative feedback on serotonin release. So whether this plays out clinically is kind of yet to be determined. I haven't heard anything about it, working much faster for patients, but that was kind of the thought behind the mechanism. This agent is metabolized by CYP3A4 and 3A5, as well as 2C19 and 2D6. So it does have some CYP450 interactions. This medication is pretty problematic for gastrointestinal side effects. So it has a pretty specific dose titration schedule that I've listed on the slide. And then it's recommended that you take it with food to help kind of with that nausea, vomiting, and diarrhea that can occur. Taking it with food also improves the bioavailability. Vortioxetine is one of the newest antidepressants. It's actually newer than vilazodone. So this one also has kind of an unclear place in therapy right now. It has multiple mechanistic properties. It works as an SSRI. It's also an agonist at those serotonin 1A receptors, so theoretically this one should also have a faster onset. And then it's an antagonist at serotonin 3 receptors, so this should reduce the GI side effects. However, the most commonly reported side effects with this agent have been nausea, constipation, and vomiting. So unclear kind of how well that's working. Vortioxetine is extensively metabolized by CYP450 enzymes, so we have to be careful with drug-drug interactions. And then dosing for this agent is fairly straightforward. In summary, our goal of treatment in depression is to really induce remission and prevent relapse. The antidepressants are equally efficacious but differ in their side effect profile, and there may be one agent that happens to work best for one patient, and sometimes it requires trying multiple agents before finding that correct drug for that patient. SSRIs, SNRIs, bupropion, and mirtazapine are considered first line due to having less adverse effects in drug-drug interactions than things like the monoamine oxidase inhibitors and the tricyclic antidepressants. It is important to monitor for suicidal ideation in all patients, but especially our pediatric and young adolescent patient populations. It's also important to remind patients that adverse effects occur immediately, while resolution of symptoms can take anywhere from 2 to 4 to maybe even 6 or 8 weeks. Thank you for your time.